Great. So thanks again for everyone coming in tonight for the webinar. I'm excited to share with you some of the work that we've done around developing a routine outcome monitoring tool. Just before I get started, whoops, a lot going on here. Just before I get started, I did want to acknowledge that this is work that was funded through the Central and Eastern Sydney Primary Health Network. They've been fabulous collaborators, and we're really excited to present this today. So just before we get started, I just wanted to highlight that there is a little bit of technical support if needed. So if you have questions or comments, there's a question and answer box that for most people I think will appear at the bottom of your screen. If you have questions throughout, feel free to pop them in there. Hopefully we'll get some time to cover all of them at the end. Otherwise, if you're having technical issues, you can see that there's a helpline and a webinar ID that you can quote if you're having any problems. In terms of other questions that might come up, either through this webinar or after the webinar, my email address is on the screen now. You're welcome to contact me at any time, either today or after, if questions come up to talk further about this work. I will have this email address on the end screen as well. So just before we get started, I'd like to just find out a little bit about who's on the poll, and at the same time I can let you know about me. So I'm just going to launch this poll so if people can let me know their background. My background is that I'm a pharmacist. I was originally a community pharmacist and then had been working in specialist drug and alcohol research services for a while. I also am a researcher, an addiction researcher, and I've been working specifically around problems with prescribed opioids for quite some time, and that's where the interest for developing a tool to help monitor for problems with opioids came about. Great, so I can see that we've got a mix of GPs and pharmacists who are online, which is great. Hopefully this is going to be equally relevant to both of you. We tried to design this work so it would be applicable to both settings. So just to give you a little bit of an overview about what we'll cover tonight, I'm going to give you a brief background on some of the opioid-related problems that have occurred. I'm going to talk a little bit about the routine opioid outcome monitoring tool and what's in that tool, and also a little bit about how the tool aligns to the 4A's framework for monitoring outcomes with opioids. And at the end, I'll just have a few slides with a little bit of information about where you can refer if you're in the assessment area and you do identify problems or have questions around patient management. So I think most people who are practicing in kind of the area of healthcare at the moment will know that we've had a really significant increase in opioid use and prescribing. So this was from a couple of years ago, but you can see really dramatic increases in opioid use, and particularly in those higher potency opioids like fentanyl, which is the green line on the left-hand picture, and fentanyl, which is the black line on the right-hand side of the picture. Part of the reason that we're worried about that is because we've seen at the same time with this increase in use, increase in harms, and this includes mortality. So this is mortality data that shows that not only are the number of people who are experiencing fatal overdoses with opioids increasing, but the majority of those are actually attributed to pharmaceutical opioids and not heroin, which now is only responsible for the minority of opioid-related deaths. So this has really put a sharp focus on trying to identify, well, if we're having problems with pharmaceutical opioids, you know, how can we reduce those, particularly when some of these mortality statistics affect people who are using opioids in therapeutic contexts. Some of the concerns with opioids, as I've mentioned, there's concerns with mortality. We've also seen increasing problems with dependence, and certainly our treatment statistics reflect that we're seeing increasing numbers every year and people coming forward who've developed dependence to their pain medications and now seeking treatments like methadone or buprenorphine. We also know that not all patients respond well to opioids, and so if we do regularly monitor, we might be able to identify where patients aren't getting a great outcome or where the risks might outweigh the benefits. And in addition to that, we've had quite dramatic changes in the recommendations about what role opioids might have in chronic pain, and certainly whether or not there's good evidence to support their long-term use is being questioned. And again, when we're not sure about the value of these medications, again, monitoring is helpful in the meantime. So in terms of, I guess this project was really around monitoring clinical outcomes with opioids. So the challenges that we know in some of our research with chronic pain patients here at the National Drug and Alcohol Research Centre has identified that while problems are pretty common, people experiencing problems are pretty unlikely to seek help, and that's for a whole range of reasons, because they're concerned that their pain medication is going to be taken away, because they're ashamed or they're embarrassed, or because of some of the stigma around addiction. So it's not likely that people will just put their hand up and say, oh, by the way, I'm concerned about my opioid use. So we have to be a little bit proactive. We also know that healthcare professionals, GPs, pharmacists and patients are all incredibly busy and time is precious. So we can't introduce things that are incredibly time consuming or laborious, particularly when we don't expect that all patients are having problems, and we just want to quickly identify those where extra care is required. And again, that chronic pain and addiction are both very stigmatised and sensitive topics, so finding easy ways to ask questions about these that's comfortable for both patients and healthcare professionals is important. So bringing together all of these things, we aim to try and develop a brief self-completed or patient-completed monitoring tool to help track patient outcomes and monitoring risks and benefits, and also to inform where referral or further investigation might be required. So most of what I'm going to talk about this evening is this room tool that you can see on your screen. You're not going to be able to see it in a lot of detail, but I just wanted to give you an overview of what the printed copy looks like. We're also testing a software version of this tool at the moment in pharmacies, and any pharmacists who are in community pharmacy in the Cesspin area that want to find out a little bit more about that, I'd encourage you to follow me up with my email address. But this is essentially the monitoring tool. It's got 5 key domains, so I'll walk through those now. The first domain is pain. So what describes your pain on average over the past 7 days, both the pain severity and the pain, how pain's been interfering with the patient's life. So that's these first 3 questions. The next 4 questions are a screening tool to identify where patients are at risk of opioid dependence, so where they're likely to meet criteria for opioid dependence. This was developed as part of this project that we've done with Cesspin, specifically because it wasn't a great tool to monitor opioid dependence. So we've actually validated this tool specifically for use with patients who are prescribed opioids for chronic pain, as most tools were developed for illicit opioid use. And that's how these questions came to be in this tool. I'll talk a little bit about more of that as we go. Next, we've got questions on mood. So this is a 2-item screener called the PHQ-2 that assesses likelihood of depression. We've got a single question that assesses risk of risky alcohol use. And then we've got 2 questions at the end that assess a common side effect with opioids, constipation. So we've got 2 versions of this screening tool. We've got the green version, which is intended for patients to complete themselves. It doesn't have the scoring on it, and it has a little bit of extra language to explain to patients why we're asking different things. The red version is the healthcare professional version. This version is not intended to be given to patients, but it's intended to help you score the patient's response. So it's got the scores in the red version, and it's also got a little bit of text explaining how to interpret the scores. But I'll cover all of that in detail now. So in terms of, I guess, how we place this tool, I think people may have heard of this term of shared decision making, and this is a process of involving patients in decision making and that being identified to be associated with better outcomes. So really working in partnership with the patient, understanding the patient's preferences and concerns, giving them information and identifying choices, and really doing this risk-benefit sort of framing. And particularly with opioids, it's really about, what's safe to prescribe and dispense, and discussing that with the patient. So the goal of this tool, and I want to be absolutely clear that this tool isn't a tool that we've developed to identify where we'll refuse opioid supply, but it's really the start of a conversation where we're going to identify where patients might benefit from additional assessment and support, and where we need to do a little bit more. But based on the tool, it's just a screening tool, it's not diagnostic, but it's going to be the first step in identifying where things might be tracking fine or where we might need to do a little bit more. So for people who may or may not be familiar, the 4 A's framework is something that came out almost 20 years ago now, in 1998. So it was developed by Steve Pasick and colleagues, and it was a framework for monitoring sort of pain outcomes with opioids. So the original 4 A's were basically the 4 domains that these pain specialists felt were really important to monitor. So this includes analgesia, activities of daily living, so this is how the pain's affecting people's life, adverse effects or side effects from the medication, and also aberrant drug-taking behaviours. So these are really our addiction-related outcomes. So you could swap that for an A of addiction. I guess in the 20 years since this has been developed, there's been a couple of other important domains that have been identified. One of those is affect or mood, that's considered the 5th A. And then alcohol use is a bonus A that we've added in this tool specifically, and I'll explain why we've done that as well. So the routine outcome monitoring tool, or ROOM tool as I call it now, is aiming to address all of these A's. So now I'm going to walk through each of the individual items on the tool, and we can discuss how they work and how they map to these domains of opioid outcomes. So first we've got the PEG. This is a 3-item tool that's been validated for measuring pain outcomes. It's got 3 questions that cover both analgesia and functioning, which is our first 2 A's, analgesia and activity. So the first question is simply a patient's pain on average over the past 7 days, and we get a score of between 0 and 10, and that's from 0 with no pain and 10 is pain as bad as a patient can imagine. The next question is, well, the next 2 questions really are talking more about how the pain is affecting a patient's functioning. So between, again, 0 and 10, how much the pain interferes with enjoyment of life and a patient's general activity. So what we can do with these scores is take an average of the 3 items, and I'll give you a number out of 10, and that's effectively the patient's PEG score. So this score can be useful in a couple of different ways. So firstly, if patients are scoring up to 4, this is considered to be mild pain. If a patient's scoring 5 or 6, this score is considered to indicate moderate pain. If a patient's scoring 5 or 6, it's probably appropriate to see how the patient's functioning and invite them, if they feel like the pain's really interfering with their day-to-day functioning, to talk to their GP or pharmacist. If they're scoring 7 or more, this is really the zone where it's considered that pain and its effect on a patient's function is severe. And if a patient is scoring 7 or more despite being on opioids, and particularly if the dose has been increasing, this is considered to indicate where maybe opioids aren't effective for that patient. Now, there's obviously a little bit of interpretation here. So if a patient had a pain score of 9, and then their dose increased and that brought that pain score down to 7, that's probably an improvement. But if the flip side has happened and a patient had a pain score of 7, their opioid dose has increased, and now they're reporting that their pain is 8 or 9, that severe pain despite opioids and despite an increasing opioid dose suggests that maybe opioids aren't the best treatment for that patient. And sometimes measuring these scores and documenting and talking to them with the patient about that can be a helpful way of illuminating that point. We also recommend, if patients are scoring, sort of 5 or more out of pain, that maybe they'll benefit from some additional resources, and that might be going to a pain clinic. But I did also want to highlight to you, you can see a website at the bottom of this slide here. It's the ACI Health website. I'm not sure if people are familiar with this, the Agency of Clinical Innovation, but they've got a fantastic website that looks at chronic pain, and they've got some patient-specific resources under Pain Bites. And if you just Google Pain Bites, B-Y-T-E-S, you'll be able to see what resources are there, and it walks patients through things like, you know, how their mood is associated with their sleep and their pain, and trying to help patients kind of manage their chronic pain by getting that additional information. So I would recommend checking out those resources yourself and recommending them for patients where they're appropriate. The other thing that you'll find on that ACI chronic pain website is a whole bunch of resources for healthcare professionals, and that includes resources to do pain assessments, more detailed pain assessments, referral pathways, all kinds of things. So if you've never had a look at the ACI website, I just wanted to flag that that's a great resource that's out there for you. So next, moving through the room tool, when we're talking about the domains of the 4 A's, the next 2 domains is adverse effects and aberrant behaviours, or our addiction-related behaviours. So these are things such as sedation, which we know is linked to falls risk, constipation, or those kinds of side effects, and also our addiction, dependence, or aberrant kind of side effects, things like overuse and overdose. So these are all adverse or unwanted effects that are associated with opioids that we're monitoring for using the ROOM tool. I did just want to talk a little bit about prescribed opioid dependence before going back to the tool. So this is, again, our addiction-related behaviours, and it's also a side effect from opioids. We know that opioids have a significant dependence liability, and then they can cause dependence. So this is our sort of 3rd and 4th A. I guess the point that I want to make here is that addiction is pretty common with patients with chronic pain. And I know when I did my undergraduate training as a pharmacist, we were taught that if you had current, you know, real pain, that you couldn't become addicted to opioids, and it was only if people are using them outside of pain context that there was an addiction risk. We now know from the research we've done in our clinical experience that that's categorically not true. So we know that internationally studies have shown that addiction is reported in between about 8 to 12% of patients with chronic pain who are prescribed long-term opioids. We've got a study here at the National Drug and Alcohol Research Centre led by Professor Louisa Degenhardt, and that's been looking at a cohort, an Australian cohort of chronic pain patients, and this is a community-based cohort. These people were recruited through community pharmacies, and they were recruited based on the fact that they'd been prescribed opioids for more than 6 weeks. So basically patients receiving long-term opioids. They weren't recruited on the basis of being problematic, and they're a pretty regular community sample. Their average age at the time that they entered the cohort was around 58. Most of them have had chronic pain at that time for around 5 years, for example, 5 to 10 years. So amongst this, you know, very average community sample of chronic pain patients, we found 1 in 4 met criteria for addiction. And this isn't just physiological adaptation to opioids, which we do expect when they're being used for chronic pain long term. We expect that people's bodies will adapt to the presence of opioids and that they will have withdrawal symptoms if they stop. But that's not what we're talking about here. What we're talking about here, when we use the term addiction, which is often also referred to as opioid dependence, is these behavioural aspects. So impaired control over use, compulsive use, continued use despite experiencing harm, and experiencing cravings. Now, there are lots of different ways that dependence or addiction is identified or diagnosed. So this is just one definition. If you use different definitions, we get similar results. So 1 in 4, 1 in 5 many criteria for dependence. I did just want to highlight when we're talking about dependence and another diagnostic kind of criteria, what that means. So the ICD-10 is just another kind of diagnostic way of identifying dependence. And to be diagnosed with opioid dependence, you need to have 3 or more of these symptoms on this slide present during the previous year. So this includes a strong desire or a sense of compulsion to take a person's opioid medication, difficulties in controlling how much opioids they're taking. We've got physiological withdrawal when the opioids are stopped, and evidence of tolerance and needing a higher dose, but those alone do not equal a diagnosis of dependence, and we expect them when opioids are used solely for medical treatment. And in fact, we found in our analysis of our cohort data that whether or not we included tolerance or withdrawal, it didn't make much difference to the the prevalence of people meeting criteria for opioid dependence. So they generally had quite a few of these symptoms at the same time. So again, these things like continued use despite harm, a lot of focus on the opioid medications and really forgetting about other things in a person's life. So when we're talking about opioid dependence, I just wanted to be really clear that if someone's screening positive for opioid dependence in this tool, it's screening positive for these behavioural aspects, not physical tolerance and withdrawal. So having gone through that little explanation, these are the next 4 questions in the room tool, and this is a prescription opioid dependence screening tool. So these 4 questions we've identified are pretty good at identifying those that are likely to meet dependence if we do a diagnostic interview. And you can see here that a score of 2 or more over the 4 items identifies somebody who's likely to meet criteria for opioid dependence. And if we see patients that are scoring 2 or more, which essentially means that they've said that they're experiencing 2 of these symptoms, at least a little bit or more. So the 4 questions that we ask patients are if they've been increasing their dose. So in the past 3 months, in the time of worse pain, did they use more opioid medicine than prescribed? We're asking them if in the last 3 months they experienced and the opioid medicines cause them to feel slowed down, sluggish or sedated. We ask in the past 3 months, did the opioid medicines cause them to lose interest in their usual activities? So this again is salient, so a real focus on the medication, and the rest things in the person's life start to drop away and the focus becomes really just on the medication. And then the last question is, in the last 3 months, did the patient worry about their use of opioid medicines? So for each of those questions, a patient would respond whether or not they experience that not at all, a little, quite a lot, or a great deal. And if they said a little or more for any of these items, that's something that we're going to look into a little bit further. So in terms of how the scoring works, if a patient scores 2 or more, and you can see the scoring here, it's whether they get it a little or a lot, it's just considered positive. So basically, if they're saying that they're experiencing 2 or more of these symptoms, that they're pretty likely to meet criteria for dependence if you administered a diagnostic or gold standard diagnostic interview such as the CITI. We also think that these individual items are important for starting a conversation with a patient, and I'll cover that on the next couple of slides. But if a patient is screening positively, so getting a score of 2 or more, this is where we recommend doing a more detailed assessment for opioid dependence. And so that might be doing that yourself, or it might be asking a more experienced addiction medicine specialist or pain specialist for a bit of advice around how a patient is presenting. The other thing to flag is that we know if patients are meeting criteria for dependence or substance use disorders, this is associated with an increased risk of overdose. So we do want to monitor these patients a little bit more carefully. So in terms of responding to the scores, a patient is either going to have a score of 0, so that they haven't endorsed any of those items, which is just great. You know, your responses indicate that you're not having any problems or concerns with your opioid medications right now. If a patient is scoring 1, so they've said one of those items, for example, they say they worry about their use or they experience sedation, but only one of those items, they're not going to meet the cutoff for dependence, but it might indicate that we want to understand that item and what's going on for them a little bit more. They might need a little bit of extra support to manage their medications or to reduce the negative impact that the opioid medicines might have on a person's life. So I've just wanted to give you some examples on if a patient responded to any one of those items, what sort of feedback you might provide. So we've got here in responding to the individual items. So the first item is sometimes needing to increase their dose. So if a patient is reporting that, you know, the kinds of things you might talk about is whether or not the patient feels like their pain is getting worse, if they feel like their dose isn't enough. If they are escalating their dose on their own without their prescriber recommending that, that's obviously problematic, and we want to talk about that. And also offer that, you know, maybe there are other ways that we can help that patient with their pain, and the opioids aren't the only solution. And again, going back to those resources that I mentioned on the ACA Pain Bites website, that might be one source where you're able to refer the patient for other strategies. If a patient's endorsing the second item, so sometimes I feel slowed down, sluggish or sedated, again, talking to the patient about, you know, how is this affecting your life? You know, is it making it hard to get out? You know, do you feel safe driving your car? You You know, maybe the dose is a little bit too high. Maybe there's other psychoactive medications that the patient's on, and we know commonly that patients are also on things like benzodiazepines or atypical antipsychotics or pregabalin, and it might be that the combination is affecting a patient's cognitive state. So again, you know, whether or not these combinations of medications are helping, maybe there's a role for a home medication review, that's HMR, or whether or not all of those medications are required, and you know, perhaps deprescribing, you know, maybe one of them. So I guess just a more general assessment of what's contributing to that sedation. It also could be potentially mental health things. If they've said, again, if sometimes they feel, you know, less interested in their usual activities, again, trying to assess if opioids are becoming too much of a focus in their life. And this could also be a mental health related symptom. So again, if that's the only symptom that they've endorsed, it doesn't indicate opioid dependence, but it might just be worth checking in. And then the final question is about whether or not patients are worried about their opioids. And I think this is timely to ask patients about, not only because patients might be worried because they're developing problems, but also a lot of patients are worried because of what's been reported in the media. So this could go two ways. You might be able to talk to them, and maybe the way that they're using their opioids is unlikely to present any risk, and you can provide them with a little bit of reassurance. Or they might be worried because some things are happening that it's helpful to talk to you about. So I guess trying to assess if there is any evidence of loss of control with the medications or harms or other indicators that there's problematic use. So I guess what we really want to pick up through this screen is if we're identifying opioid dependence. So that's saying that they're experiencing at least two of these symptoms in the past 3 months. So any combination of two or more. So increasing their dose, feeling sedated, sluggish, losing interest in other activities and worrying about their use. So if they're scoring 2 or more on this section, they have screened positive for opioid dependence. It indicates that problems exist or that they're emerging. And that this indicates that a more detailed assessment of dependence is needed. So, and then we're talking about assessing against the ICD-10 or DSM-5, you know, substance use disorder symptoms. And again, if you don't feel confident in assessing opioid dependence, at the end of this presentation, there's a range of contacts that I can put you in contact with. And it might be this is a really great way to work with drug and alcohol services. In terms of what you might do if a patient does seem to be losing control of their medications, I just wanted to mention a couple of strategies that are out there that you can access. So we know, I already mentioned home medication reviews. This might just give a better understanding of how a patient is using their medications and what else is happening at the same time. One of the strategies that can be implemented relatively easily is stage supply. So this is where we get a pharmacy to be dispensing medication more often. So perhaps rather than a month's supply at a time, maybe getting a week's supply or even a couple of days' supply at a time. So this might just help a patient control how much they're using. You could have some supervised dosing. It'll also get a little bit of additional monitoring from the pharmacist around what's happening for that patient. They'll see them a little bit more often. For many patients that are having trouble controlling how much opioids that they use, this can be enough, this bit of structure to try and get things back under control, and you might not need to do a lot more. If those things have failed though, and you've tried stage supply, you've tried to do an assessment and it just seems like things are getting out of control, that's probably the point that you might want to get a referral for a specialist assessment, so a pain or addiction specialist, and start to do a more detailed assessment and get a collaborative plan around what's going to happen. When we're starting to move through all of these things and we haven't been able to get control over an opioid, over the amount of opioids that a patient's using, and you really are concerned about dependence. And there are options including opioid pharmacotherapies that are traditionally delivered in an addiction treatment framework. This is really only appropriate where we've got a diagnosis of opioid dependence and perhaps you've tried and failed with these other strategies to put a bit more structure in place. But we do have options like buprenorphine taper, buprenorphine maintenance and methadone maintenance. And we actually know that buprenorphine and methadone are very good analgesic medications, and we have good evidence to show that these are effective for patients who have opioid dependence and chronic pain. So these are absolutely options that we can consider. So now I'm going to move to the next part of the tool, which is affect or mood, so which has been proposed as the 5th A. We know amongst patients with chronic pain that half meet criteria for moderate to severe depression, so it's pretty common. And we also know that 1 in 5 have attempted suicide. So again, a high-risk patient group. The other reasons that we might want to assess mood in an ongoing way is because low mood can affect not only a patient's pain, but also how well they sleep. And then we also know that patients with chronic pain, if they don't sleep well, that can affect how well they're able to cope with their pain. So it can become a real vicious cycle. What we've included in the room tool is a 2-item screen to identify those that are likely to meet criteria for depression. So this is the PHQ-2. It's validated. It's a very good instrument that there's lots and lots of evidence to show that this works pretty well. If patients can self-complete this, you can see the scoring here. This is the scoring that's on the healthcare professional version. Obviously, the patient version doesn't have the scoring. But patients are asked these 2 questions about how they've been feeling over the last 2 weeks. And depending on how they answer, we can identify patients that are probably experiencing depression and or anxiety and where some further assessment is warranted. So where a patient scores 3 or more, then further assessment is indicated. So if they're scoring less than 3, that indicates that they're not currently reporting these symptoms at a level that we need to do assessment. The sorts of things we might do if a patient's scoring 3 or more, so a positive screen for depression or possibly anxiety is, the GP can obviously do an assessment, and GPs are very skilled at doing these kinds of assessments. It might be appropriate to look at a mental health care plan, and we also know that things like CBT and that can be helpful for depression and anxiety and insomnia are also really great at managing chronic pain. So that might be a really good step for a patient that is meeting these criteria. Also, if a patient would like to get some access to self-help resources, there are lots and lots available, and I've just got Beyond Blue there as one website, but there are lots of online resources, and I've actually got an article on online resources for mental health, and I'm very happy if anyone wants to email me to share that article with you. It does kind of give an overview of what's available in Australia. So the final domain that we ask about in the room tool is alcohol use, and the reason that we included this was because some of our research with our cohort study of chronic pain patients identified that up to 1 in 3 people with chronic pain who are prescribed opioids report a lifetime alcohol use disorder. So it's relatively common that at some point people have had problems with alcohol. And we also know that alcohol is really commonly involved in opioid-related deaths. And it's often this combination of sedatives, benzodiazepines, alcohol, opioids combined. So it is good to pick up if people are using higher amounts of alcohol. And we also know that alcohol can interact with not only the patient's medication, but also their sleep and their mood. So again, if we can identify where there might be problematic alcohol use, we might be able to improve overall outcomes for patients who have chronic pain. I do have a link there to a little article on opioid interactions with medications that, again, I'm happy to share with anyone if they're interested. The single question that we've got in a screening tool, and this is a single item that's been validated to be pretty good at identifying people who are drinking at risk. So it asks how many times in the past year the patient has had 4 or more for women or 5 or more for men drinks in one day. And so just answering 1 or more occasion in the past year is actually a really good screen for a patient that might be drinking at risky levels. So if they say 1 or more occasions in the past year, we would recommend to do a more detailed screen, and there are lots and lots of great screening tools out there. The one that I've mentioned here is the audit. So this is a 10 question screening tool for, I guess, getting a bit more of an idea about risky alcohol use and possible dependence. And depending on the outcome, it might be appropriate to do a brief intervention on the pharmacy or the GP setting. I just wanted to cover a little bit about how you might respond, because we know there's not a lot of use in asking about drinking if you don't feel confident to talk to a patient about it. So the first thing I wanted to say is that we know that brief interventions are pretty effective for some people. So there's been research showing that a 5-minute intervention, a 5-minute discussion with a healthcare professional can reduce a patient's alcohol consumption by 1/3. So that can really bring down their likelihood of having harms with alcohol and also the likelihood that it'll interact with their opioids. This brief intervention can include asking if the patient wants information, discussing risks and concerns, possible benefits of drinking less, and also asking or providing advice about interactions with alcohol and patients' medications and the effect of alcohol on mood and sleep. Now, not all patients are going to want to talk about alcohol, and that's fine. The main thing is that we offer, and that patients know that you are a person that if they're ever concerned and they want to talk to you, that they can. I'll cover in the next slide a little bit of information, but if a patient says that they're not interested, that's fine. Just let them know that if they ever want to talk about alcohol use, that you're happy to chat with them, and you're happy to do that at any time. So this is, I guess, a summary of a 5 A's kind of model of intervention. People might be familiar with the 5 A's through smoking cessation. It's also equally applicable to other drugs, other substance use. So the 5 A's, the first A is ask, and this is really not only asking about alcohol use, but also asking permission to talk about alcohol use. So, I'd like to talk to you for just a minute about using alcohol with your pain medications. Would that be okay? And if the patient says no, again, that's fine. Just know that I'm here and I'm happy to talk to you at any time. The second A is assessing. So really assessing the level of risk. So using some of those more detailed screening tools, and also assessing a patient's motivation for change, and potentially doing a little bit of motivational interviewing if it seems like the patient's having trouble identifying why they might change. And that can include talking about, possible benefits that they might find from drinking less, or any negative effects that they're finding from their drinking. The third A is advise, so providing written and verbal information. The fourth A, assisting the patient with self-management strategies. That can be as simple as if a patient is drinking every day, maybe trying to identify a couple days a week that they plan not to drink. And when they get home, rather than opening a beer or pouring a glass of wine, making a herbal tea. Concrete things that can have measurable outcomes, number of days, number of drinks, swapping out non-alcoholic drinks, those kinds of strategies. There's lots and lots of good information about alcohol brief interventions, and I'm happy to share resources with you. But that's essentially an overview of what that might look like. And then the fifth A is arranging. So if it's a pharmacist identifying risky drinking, it might be arranging a referral to a GP for a more detailed assessment. And if it's a GP, it might be arranging a referral, or even offering that the patient could do a self-referral to a drug and alcohol service, and just letting patients know that that's something that they can do. And I do have drug and alcohol referral information at the end of these slides, so we'll talk about that a little bit more. So the final part of the tool that we ask about is constipation. So we know constipation with opioids is very, very common. And we also know that constipation can really affect patients' quality of life. There are lots of lifestyle factors that are important, so things that patients can modify, like diet, hydration and exercise, that can contribute to reducing constipation. And then not all patients use appropriate laxatives, and that's partly linked into the fact that patients are unlikely to ask for help. And we did some consultation with patients with lived experience with chronic pain and opioid use, and they talked about the fact that constipation is embarrassing and they're not likely to bring it up. So it is good to kind of ask about this routinely. The other thing to consider is, because it is embarrassing for patients, they might be self-managing their constipation, and they might have chosen a laxative from the supermarket or the pharmacy without talking to somebody. And so you can check in about what they're using and make sure that that's appropriate. So in terms of the questions that are on the room tool, there's 2 questions. The first is asking about if they are experiencing constipation, and then the second is asking about if they're experiencing constipation, if they're taking anything for it already. So with the answers for these questions, you can identify if their use is problematic, if they're using an appropriate medication, and also chat about lifestyle factors if that's relevant for the patient. And again, this is something where a home medication review might also identify where there's other medications that could be contributing to constipation as well. So as far as recommendations for opioid-induced constipation, I've got a link on your screen to a therapeutic brief on opioid-induced constipation. I'm happy to email that to you, or you can just Google it. If you Google therapeutic brief and opioid-induced constipation, this is probably going to be the first link that comes up. So their recommendations are that when starting opioids, that a combined stimulant laxative with a stool softener is ideal, that osmotic laxatives might be appropriate where you've got non-responsive constipation, and generally bulking agents are not recommended for patients with opioid-induced constipation. So I guess the fibre supplements and things may increase the risk of constipation, particularly so if patients have poor fluid intake or if they're immobile, which can happen with chronic pain. So just to avoid those. So I've got a question here about whether or not that patients often say, sorry, I'll read the question out to make it easy. So many times when I ask patients if they're constipated, they say no. Any tips on getting over that barrier? So I guess rather than asking a closed-ended question like, do you have constipation, you could ask a more open-ended question like, can you tell me a little bit about your bowel function? And you can also normalise it, so introduce it by saying, look, we know most patients when they're taking opioids can experience these symptoms. And, you know, just ask, you know, can you tell me a little bit about what's happening for you? So that might be one way to, open up that conversation. The other thing is not to assume that patients know what you mean when you say constipation. So I guess trying to explain that it can be when, you know, it's more, you know, when it's more difficult to go to the toilet or when, you know, I guess walking through the symptoms. So you're not just assuming that they know what constipation means, but talking them through what that can mean. So, I mean, that would be my advice on one way to raise that conversation. Hopefully that helps. So other overdose risk factors, there are just a couple of things that I wanted to flag in terms of overdose risk factors that you might be aware of while you're doing this tool. And it's likely if you're a patient, if you're a pharmacist or GP and you're talking to patients with this tool, that you've also got some other information about the patient that will help you identify if they do have other risk factors. So this can include whether or not a patient's been increasing their dose or if their dose has just gone up, so they've gone to a higher strength fentanyl patch, for example. If they're also using other sedative medications, if they happen to be using multiple prescribers or pharmacists, we know that this is something that does increase the risk of, or is associated with an increased risk of overdose. And this is something that, you know, I guess when we get prescription monitoring, this will be easier to pick up, but you might get some clues about this, particularly in pharmacy settings. And also those on higher opioid doses. So in particular, an oral morphine equivalent of more than 100 milligrams is associated with an increased risk, and even above 50 milligrams, the risk goes up quite a few times from doses below 50 milligrams. If we do identify overdose risks, one thing that we can offer, and can be a really patient-centered discussion, is naloxone. Pharmacists can offer this without a prescription, but it is expensive. So if you're a pharmacist and you're talking to a patient who is on a concession card, it would be good to ask them, you know, maybe to talk about that with their GP. And if you're a GP, to talk about whether or not this is appropriate for a patient and perhaps give them a prescription, because it will save them. I think for them to purchase naloxone at the moment with the products that are available, it's going to be around $75, $80, which is quite a lot. So with a concession card and a script, that would be $6.20. So I'm going to cover naloxone a little bit here, just because talking about naloxone, whether or not the patient actually takes it, is one way of really highlighting that there is an overdose risk and that you're concerned about the patient's safety. So in terms of whether or not this is a good thing to do with chronic pain patients, because this is a question that I've had a number of times, and so to try and understand that, we actually did a little bit of research on this, and this was published earlier this year. So this was looking at chronic pain patients, both their knowledge of opioid overdose and their attitudes towards naloxone. And we found that when we explained what naloxone was and the idea that this is a medication that you can keep in your home and that a family member or carer could administer it to you if you did have opioid toxicity or an opioid overdose event, when we explained what it was for and how it would work, most patients, so the majority of patients, I think it was around 2/3, 3/4, so that they would expect or appreciate being offered this by their prescriber or pharmacist. So it's pretty common that people would like to hear about this and they generally won't know about it. And also when we asked them if they thought this was a good idea, most patients thought it was a good or a very good idea. But what we also found when we talked to patients about their knowledge of overdose risk is that they didn't really know what the signs and symptoms of opioid toxicity were. So we gave them a list of possible opioid toxicity signs, and they couldn't really pick which ones were associated with opioid overdose. So not only do we need to talk to patients about the risk and educate them on things that can make their opioids safer, we also need to tell them what opioid toxicity actually looks like. And it is really ideal to educate not only the patient, but their family members or carers. In terms of supplying naloxone, other things that we've learned from the research is that opioid overdose can occur with prescription pain medication, not just if a patient's intentionally taken more, but for a whole range of reasons. And often patients think, well, I'm not going to overdose. I don't do anything wrong with my medication. And I guess we need to reassure them that opioid toxicity doesn't mean that they've done anything wrong. You know, sometimes it can be because they've got confused, they've taken extra medication. It could be because their pain was particularly bad and they've taken extra medication. Or it could be because they've taken other medications that interact with their opioid medication, or there's a change in their health. So, for example, a change in the way they're metabolizing their opioids, and particularly with opioids like methadone or long-acting opioids, we can start to get accumulation when there's a decreased liver function. So it's not necessarily about the patient doing something wrong, but these risks are something that are inherent with the medications, and it's good to talk about them. In terms of educating about signs of opioid toxicity, this includes lack of consciousness, blue-grey lips, no breathing or slow breathing, or this sort of snoring, really deep snoring sound. We know that most patients won't recognise these symptoms, and we also know really tragically that a recent analysis of fatal prescription overdose deaths in Australia found that many occur in the presence of somebody else. So someone else was home at the time, but that somebody else did not recognise that there were symptoms of the overdose. So they actually described hearing this snoring sound, but they thought the patient was just sleeping and they ignored it. So we can potentially identify or educate patients and their family members on what signs to look for. Just a couple of points on overdose management. So key points include always call an ambulance even if the naloxone works, where to administer the naloxone, so in the upper arm or thigh. I think I've got a diagram in a couple of slides. If the person's not breathing, to start rescue breathing, put them on their back. If they are breathing, put them in the recovery position, and to let the family members or carers know that they can repeat the dose if they don't get any improvement, and it's safer to give more rather than to hold off. This is the one product that I believe is available at the moment, Prenoxate. It's a pre-filled syringe. It is available in wholesalers in Australia. You can order that into the pharmacy if a patient does require it. And it has everything that they need in the kit, which is quite handy. It's a little bit more simple than the ampules. There is an overdose plan that you can download from the Pharmacy Guild to give with that naloxone when it's supplied, to make sure that patients know how to use it and to keep this handy, because it's likely that all this information you give them that they'll forget, so they can remind themselves at the time by keeping this with naloxone. And then just in terms of administration, so you can see in this diagram here, we have it in the upper arm or the outer thigh. We expect it to work within 2 to 5 minutes, so again, a second dose can be given. And also to inform patients and their family members that the half-life isn't that long. So to stay with the patients, they can return to an overdose state even if that first dose works. And so always to call an ambulance and obviously let the ambulance person know that naloxone has been administered. But just to, even if the patient looks quite good after the dose has been administered, you still want to get that person checked out. So I guess a couple of final points. I think that we've had a real shift in knowledge around opioids, so it is useful to discuss with patients that our understanding of the role of opioids in chronic pain has changed. So we know now that often those higher doses are associated with fewer benefits, and as patients' doses escalate, they often report less pain relief. And those higher doses are also associated with increased risk of overdose. So again, bringing patients back down can have benefits, not only in terms of their pain responses, but also for safety. And there is limited evidence showing that opioids are effective in the long term. So if we're doing this routine outcome monitoring tool and we're identifying that there are significant risks and they outweigh the benefits, it might change the discussion. And really focusing the discussion on this is really about what's safe and effective for the patient. So it's not about being policemen taking people's opioids away, but it's really responding to the best knowledge that we've got now about how opioids work. And it might be through doing this monitoring tool that we can easily see that some patients are doing just fine and we don't need to do any more. The other thing that came up really strongly through some of the consultation that we did as part of this project is that how we talk to patients about opioids is as important as what we tell them. So these are very stigmatized conditions, not only opioid dependence, but also chronic pain. There's a lot of stigma. And patients are really sensitive to being judged, and very few are going to come forward and seek help. So I guess, again, framing it as in this, we know this is a problem with the opioids. It's not that these are bad patients, but these are imperfect drugs. And also just to highlight that it's unlikely that you're going to really change everything in a day, but using this outcome monitoring tool is a good way to start the conversation and to express empathy and build rapport. And hopefully if things are a little bit, there is signs of overuse or there are signs of problematic use, that we can start to get things on the right track. So just a couple of examples. I know often I get feedback that people like to have kind of statements that they can use. So some of these questions, can we talk about better ways to manage your pain? So not just focusing on the opioids, but focusing on the outcome for the patient. Can we look at ways to improve your quality of life? So again, some of the things that will come up through this routine opioid outcome monitoring are going to be things like mood and side effects that might be really affecting a patient's quality of life and that we can modify. And also talking about ways to reduce the risk of a patient's medications. So again, talking about naloxone, can I provide you with naloxone to keep at home just in case, and train a family member or carer on how to administer it. So these are just a couple of things that we might be able to start discussions around. And then I guess if things really are at that serious end where you've done this routine outcome monitoring and you've identified some things that really suggest that there are significant concerns, there might be patients where you do consider that deprescribing of opioids is appropriate. And the sorts of indicators that it would be appropriate are things like where patients have severe pain despite an adequate trial of opioids. So I mentioned at the earlier slides that a score of 7 or more out of 10 indicates that a patient has severe pain despite being on opioids. If they're not getting an improvement of pain or functioning, so again, those second 2 items on that PEG tool that are asking about, how much pain's interfering, that'll give you an idea of if the opioids are really helping the patient. And then those opioid-related complications, so sleep apnea, overdose risk, dependence, loss of control over use. So I guess really we're talking about when taking all of the information on balance, the risks are outweighing the benefits for that patient, and talking about it in collaboration with the patient. So hopefully the patient's on board and will work with you on this plan as opposed to pulling out stumps and just going and finding another doctor that would prescribe the opioids for them, for example. So just a couple of slides and then we'll have some time for questions. So I'm not sure if people are aware, but there is a 24-hour consultation service that you can call. It's free for healthcare professionals. I mention this in many of the presentations I do, just because it's a really great service. So if you're in the metropolitan area, there's a metropolitan number. If you're in a regional or rural area, again, a specific number to call. And this is so that you can get help or advice if you feel like you're not sure what's safe to do for a patient. If you've got concerns about assessing whether or not there's a drug and alcohol related problem and how to manage it, you can call these numbers and get advice. And this is particularly helpful after hours, which is often when problems can crop up. There's also a current project called the GP Liaison in Alcohol and Other Drugs project, or GLAD. This is again funded by the Central and Eastern Sydney PHN, so it covers that geographic area. And depending on where you are, you'll know which is the best local service to call. But you can call these numbers to ask about advice from the on-call drug and alcohol doctor if you want to get sort of some immediate help, and also to set up a referral if you think that's appropriate for a patient. In terms of pain clinics, there also, I think, one thing that's often raised is that there's huge waiting lists and we can't get patients in. I just had a look on the health pathways. This is just a Sydney one, so depending on where you are, log into your own health pathways. If you don't know what health pathways is, again, feel free to email me. But this is for Concord. If you're in the Concord area, the waiting time's currently 2 to 3 months for non-urgent cases and a little bit faster for urgent cases. And that's the phone number that you can ring to find out how to refer a patient in. And then if you're in the RPA area, again, wait times vary depending on severity, but for urgent cases, we can, they indicate that often within a week they'll see a patient. If it's, other urgent things, maybe within a month. Routinely, it's within 3 months. So it's not the 12 to 18 months that I think that people are familiar with. And again, there are other programs as well, like the STEPS program, where people can start to do this sort of pre-assessment program while they're waiting for a referral. So again, there's the details. There are other pain management services in the assessment area. I didn't want to spend hours talking about all of them. But you will find those details in Health Pathways if you have a login for that, and that is a free service to access. So that's the end of my presentation today. In terms of questions or feedback, if you have questions, if you can see the Q&A section is probably on the bottom or the side of your screen, depending on which way you're looking at your screen. I'm open to answering a couple of questions now in the few minutes that we've got left. Also, if you'd like a copy of the tool that I've been talking about, I can provide you with a PDF, and you're welcome to use that in your practice. I would love to have feedback. We've done consultation around the development of the tool, and we've done validation of the items in the tool, but I'd really like to get your feedback on how you go using it in your practice and any suggestions that you have. We're also currently doing an implementation study in community pharmacy. So if you're a community pharmacist in the assessment area and you wanted to be involved in that study, again, feel free to email me. I'd love to hear from you. So I'm just looking at the questions. So I've got a question, is the Room tool a validated tool that can be used in practice? So let me tell you a little bit about the validation with this tool. So the individual items on the tool have all been validated. We developed the opioid dependence tool ourselves, and we did the statistical validation based on data from chronic patients prescribed opioids in Australia with the current study that we've got. So we developed and validated that opioid dependence item specifically for use in chronic pain patients. The other items that are in there, so the items on mood, the items on risky alcohol use, they are already validated items that were out there. We have actually done another validation study to test these items for online self-completion, so we're doing that analysis at the moment, but there's nothing in this tool that hasn't already been developed and tested. So it's essentially we've pulled together these questions. So I've got I've got a couple of people that have just emailed through asking if I could send the slides and the tools. Absolutely. If you would like to receive the slides and the tools, you can either email me directly or you can pop your email into the question and answer box, and I'll be able to grab those as well. So we've just got a minute or so to go. If there aren't any final questions, I'd really like to thank you. I know that people have a lot of demands on their time, and I really appreciate you dialing in for the webinar. We will have a pre-recorded webinar that goes up onto the Central and Eastern Sydney PHN website, so we'll be able to pop that up as well. So yeah, great, thank you. I'm getting some thank you messages on the question, and thank you, I do really appreciate that. So yeah, so thanks again, and I will, if you've provided me with your email address in the Q&A box, then I will, I'll send those tools to you in the next couple of days.